When you first start out in the NICU, you order a lot of blood counts, and pretty often the platelet counts come back to be low. And sometimes it's moderately low, like 60, 70, 80. But sometimes it's really low down to single digits. But either way, that little number can leave you unsure of what to do next. And here's one tricky thing in neonatology. The differential diagnosis in the general pediatrics or in internal medicine somehow cannot transfer well to neonatology. They have different complete differential diagnosis. So the instinct you have built elsewhere usually don't quite fit here. And usually you feel quite unsure when you just begin your neonatology journey. But that's completely normal. So this video is to help you approach a baby with low platelet count step by step. So if you're new here, I'm Dr. Oliver. I'm a pediatrician working about 10 years, and I start this channel Paediatric Squad to help the beginner pediatrician to get through the steep learning curve, and I hope this channel can really help. Alright, so let's start with the basics. Neonatal Thrombocytopenia. Basically, it just means a low platelet count in a newborn. And what is low? Under 150. So platelet count under 150, we call it thrombocytopenia. And the first thing worth knowing is that this is common, and much more common than you expect. So actually up to 1 in 4 babies admitted to the neonatal unit will have it at some point. And for the tiniest baby under 1 kilo at birth, it's around half of them will have neonatal thrombocytopenia. So usually we sort it into 3 groups. Mild thrombocytopenia means 100 to 150. Moderate is 50 to 100. And severe is under 50. So most babies falls into the mild group, and it's usually just the body responding to some stress. For example, being born too early or being too small, and usually this mild thrombocytopenia will settle on its own. And only about 5% of the babies on the unit would reach the severe range. And those are the ones we pay close attention to. Chapter 2. So if you can only remember one thing from the whole video, I hope you can remember this. When a newborn has a low platelet count, you should ask one question: when did it start? Because the timing can tell you what are the causes. So traditionally, we split it down in the middle at 72 hours of age. So if the low platelet count show up in the first 72 hours, we call it early onset. And if it happens after 72 hours, it's late onset. And here's why it's so useful. Because these 2 groups have completely different stories behind them. So when it's early onset in those first 3 days, in terms of the causes, think about the mother and the placenta. The baby's platelet are usually low because of something that was already going on before birth. For example, problems with the placenta, a difficult delivery, an infection passing on during the pregnancy, or there's some antibodies from the mother. And in fact, early onset is the bigger group. About 3/4 of all causes you will see in the neonatal unit. But when it's late onset after day 3, the story is completely different. So now you are thinking about the babies getting sick right now in front of you. That's something acquired instead of congenital. Usually it can be due to like infection or problem in the gut, and the baby is unwell and the platelets are dropping because of it. So just to recap, early onset before 72 hours, think about mother and the placenta. Late onset, think about the baby is sick now. And just keep that in your mind, and we will cover it one by one in the next chapter. Chapter 3, early onset. Let's talk about the early onset group first. When you see the baby is having thrombocytopenia in the first 3 days, you should ask yourself 2 questions. When did it start? And whether this is a production problem or a destruction problem. Alright, so early on, most of the time, is the production problem. And the number 1 cause is the placenta is not doing its job. So the babies with intrauterine growth restriction, the preeclampsia pregnancy, the mother with gestational diabetes, and whenever the placenta is struggling, it will tell the baby's bone marrow to slow down the platelet production, and the factory just won't slow for a while. So we call this megakaryocyte suppression, and that means the cell in the bone marrow slow down and make the platelet production slow down. Alright? But the good thing about this baby is that they usually look well. when the platelets goes down, they will have the lowest point at around day 4. And then it will climb back on its own at around 10 days to 2 weeks. And it rarely drops below 50 because nothing is actively eating the platelets. The bone marrow is just getting a bit lazy. So for this baby, the main job is closely monitoring, all right? And there are 2 other causes that can cause early onset thrombocytopenia, which can slow down the production of the platelet and also burn the platelets up. So they are kind of a bit mixed. First is difficult delivery, perinatal asphyxia. So if the baby is having rough delivery, low ECGA score, or they need resuscitation or even show signs of HIE, usually they will have low platelet count. And secondly, is congenital infection. It's like CMV, toxoplasma rubella. And CMV is the one you will see most. So if the platelets stay low and the baby isn't fixing the usual picture, those are worth thinking about. And then there's the immune group. So whereas the problem is not production and it's destruction problem. So it can be the antibodies from mother crossing the placenta and destroy the baby's platelet. And these are the 2 causes. So the first is the fetal and neonatal alloimmune thrombocytopenia, or FNAIT. Alright, so what is this actually? Think of it like rhesus disease, but for the platelets. The babies inherit a platelet marker from their father that mother doesn't have. So the mother makes antibodies against it, and these cross over to the placenta and destroy the baby's platelets. So the classical picture of this problem is usually a well-looking term baby who suddenly has a very low count or widespread platelet K, and crucially, the mother's own platelet count is completely normal, unlike rhesus disease. And unlike rhesus disease, this can happen in the first pregnancy, so a healthy first baby doesn't reassure you. It's uncommon, but we take it seriously, because the real fear is that when the platelet count goes too low, it can lead to intracranial hemorrhage. Therefore, every suspected cases, we should do an ultrasound brain. And the ideal treatment is some special platelets that lacks the marker that mother react to, and also plus the immunoglobulin if needed. Alright? And second cause of the destruction of the platelet is when the mother had autoimmune condition herself, like ITP or SLE. Here's one clue that you can find in these kind of babies. When you check the mother's platelet, they are low too, or the mother has a known autoimmune history, and her antibodies can cross over the placenta and destroy the baby's platelet, leading to neonatal thrombocytopenia. So that's the early onset group. Mostly it's due to production problem, the placenta problem. Also, it can be due to destruction like the mother's antibodies, autoimmune condition, or autoimmune condition. And we should ask when did it start, and are they not making them or just losing them because of destruction. And by the way, if you're finding this useful, I've made a free pediatric resuscitation formula cheat sheet and one for developmental milestone cheat sheet, so that you don't need to have a thought block during your 3 a.m. night shift. You just take it out from your pocket, and it's completely free, and the link in the description below, so grab it if this is helpful. Chapter 4. Late onset causes. So now let's talk about the late onset causes of thrombocytopenia. After the first 3 days, if you see thrombocytopenia, the story is completely different. In the early group, the babies was often well, and in the late group, it's the opposite. This is the baby who is becoming unwell in front of you. And the mechanism is almost the third on our list: consumption. And the platelets are not being underproduced, and they are not being attacked by antibodies. They're just used up very quickly because the baby is fighting something big. And the 2 most important causes to remember are sepsis and NEC. So the sepsis is the late onset infection, so it can be either bacterial, viral, or fungal. And the NEC is necrotizing enterocolitis, especially in preterm baby. And also, it can be the third causes like spontaneous intestinal perforation, so where the bowel perforate on its own. And in all of this, there's a huge wave of inflammation, and these inflammation can actually consume the platelet very quickly. And sometimes the baby can even go into DIC, and where the whole clotting system starts to have problem. So what does this baby actually look like? Versus early onset, they're usually not well. Alright, so This is the babies who suddenly having more apneas, or suddenly their abdomen looking distended, or there's some skin changes over the abdomen, and who's just not right. The CRP can suddenly goes up and the platelet drops. In these cases, the platelet tends to drop faster and deeper than the early onset group. They usually reach its lowest point within a couple of days, and this usually lasts for longer. But there's one very important concept. In this baby, the low platelet counts is usually not the main problem. It's usually a warning sign. It's telling the baby is not well. So when you see the platelets falling after day 3, don't just blindly go for a transfusion and move on. Do ask yourself, is this baby developing sepsis? Should I do septic workup? Is there something going on the gut? Palpate the abdomen. So look at the chart whether the baby is having more apnea. Treat the baby, find the cause. The platelets are just signal. Alright? So to recap, late onset thrombocytopenia, think about the baby is sick and the platelets are being using up. That's the whole picture. Chapter 5, persistent and unusual causes. So let's recap a bit here before we go further. We time the neonatal thrombocytopenia early or late onset, and we ask about the mechanism. Are they not making the platelet, destroying them, or just using them? So early onset is usually due to placenta problem or mom's antibody destroying them. Late onset is usually the sick baby using the platelet up. But sometimes the story just doesn't fit. When you see the cases with persistent low platelet count, which means if the platelet count persistently low after 2 weeks, that's unusual. You should think about other causes. Because by now the babies with placenta problems should have recovered, the sick babies should have been treated. But when this thrombocytopenia is persistent, we need to think about 3 things. Alright, first thing is congenital infection. And again, as I said, CMV is the most common thing. And secondly is the immune cause, like the autoimmune condition. And thirdly, that's the most important thing, is the inherited problem. So this inherited problem brings back our production idea. So in the most extreme form, in inherited thrombocytopenia, the bone marrow, the factory, was never built properly. So what are the cues? The cues are not in the timing, but they are on the baby and in the family. So these baby may have physical abnormalities, for example, TAR syndrome, where their forearm bones, the radius, are missing, or physical outreach. Think about small platelets. The baby can have severe eczema, or they have immune problem with frequent infection. And always ask about family history, whether the family having some problems with the platelet, because these can run in the family. So how should we investigate these babies? 2 simple things. We look at the blood film, look at the actual size and shape of the platelets. Sometimes they can give us some clue. And increasingly, now more commonly, we send genetic tests. So that's how you confirm the diagnosis. But I think here in this video, the message you should get is, if you got a baby with persistent unexplained low platelet, like not sepsis and is persistent more than 2 weeks, and especially in those with unusual features like dysmorphism or they have family history, that's the moment you should discuss with your hematology and genetic colleagues and think about any inherited causes of thrombocytopenia. Chapter 6, management. So now, when you see a baby is actually having a low platelet count, what should you do about it? And I want you to remember this golden rule: treat the baby, not the number. So when you're a new pediatrician, it's so tempting that when you see the scary number of the platelet, you reach straight for the platelet transfusion. But here's one thing: the platelet count on its own is a surprisingly poor guide to where the baby will actually bleed. Some babies bleed with the counts that are not very low, and plenty of babies are completely safe even with very low counts. So the number by itself just doesn't tell you enough. What do we look at instead? We look at the actual symptoms of bleeding. Is the baby actually bleeding? And if the baby is bleeding, how bad was the bleeding? So we usually grade it into 4 levels: minor, moderate, major, and severe. So minor bleeding means the bleeding from skin or a little bit old blood in the ET tube, those pink secretion. Moderate is something like a fresh rectal bleed or fresh blood in the ET tube, but the baby's breathing hasn't changed it. And major is the fresh bleeding in the ET tube that's making the baby harder to ventilate, or there's a large bleeding inside the brain. And severe bleeding is the bleeding heavy enough to affect the baby's circulation. They can have shock. So we put the bleeding picture together with the number, and that gives us our transfusion threshold. And I want you to remember 3 numbers: 25, 50, and 100. So 25 is the line we use most of the time. So for a stable baby who's either not bleeding or just bleeding a little bit, we hold off until the platelet falls below 25. And 50 is for the baby with moderate or major bleeding, because if there's real bleeding going on, we step in earlier. And 50 is for the baby with moderate or major bleeding, because if there's real bleeding going on, we step in earlier at under 50. And 100 is safe for the big one, like major surgery or there's already severe life-threatening bleeding. So to keep it simple, no or minor bleeding, the line is 25. Moderate or major bleeding, the line is 50. And surgery or life-threatening bleeding, the line is 100. Now you may be thinking, why 25? Why do we let it drop that low before we transfuse? For years, we actually didn't. We used to transfuse much more freely just to feel safe. And actually there's one big important study. It's completely changed the way we practice. Chapter 7, the Planet 2 game changer. So why 25? Why don't we transfuse the platelet earlier? The answer comes from a study called Planet 2, and it's worth knowing because it's genuinely changed how we practice. So here, what they did. They took 660 premature babies, all under 34 weeks, and all with severely low platelet count, and none of them have active bleeding. And they tried to split them into 2 groups. One group got a transfusion whenever the platelet dropped below 50, which we call the generous approach, and the other group just wait until the platelet count dropped below 25, and a careful holdback approach. And then they simply watch what happened. So now you may expect the generous group, the one getting more platelet or sooner, to do better. That feels safer, right? But the result was completely opposite. In the group transfused at 50, 26% of the babies died or had serious bleed. And in the group they just transfused when it dropped below 25, it was only 19%. So the babies who got more transfusion actually did worse, and these results surprised everyone. So why would giving platelet cause harm? So there are a few reasons. The platelet we give are actually from adult donors, and the adult's platelets behave differently in a tiny baby. They are more reactive. They may trigger clotting in the wrong place, including the baby's brain vessels. And on top of that, the baby's transfusion is a big volume for their size, so it can overload their circulation. And there are signs that these transfusions can actually lead to inflammation that can worsen the baby's lung. And when they followed these babies up 2 years later, the generous group still had high rates of death or developmental problems. So it seems that there was harm, and it can last for a bit of time. But there's one pitfall here. You should not over-apply this study, because this study, they included babies who were not actively bleeding. So this is about prophylactic transfusion, topping up the number. But it's not about a babies who truly have a hemorrhage in front of you. So if a baby is bleeding badly, of course you need to treat that. But the lesson is simple. A platelet transfusion is not a harmless top-up. Therefore, we come back to our golden rule. Treat the baby, not the number. You see the baby whether they have the bleeding or not. For watching until now, let's wrap up a bit of what we have covered. So when you see a low platelet count, ask when. Whether it's early onset or late onset, the timeline is 72 hours. If it's early, think about placenta problem or mother's antibody. If it's late, think about the sick baby using the platelet sub, and ask yourself the mechanism. There's production problem, or something destroying them by the antibodies, or something is consuming them like the DIC or severe sepsis. And when it comes to treatment, look at the baby and the bleeding, not just the number. Think about, remember 25, 50, and 100. Whether you transfuse or not depends on the severity of the bleeding. So that's the whole approach, and I hope this can help make you feel less scared when you do your neonatal rotation. If this help and you want more like this, actually I also write newsletter for Paediatrician where I share my own experience, the lessons that I've picked up throughout these years, or sometimes there's some updates to the guideline or papers. So if this sounds useful, the link of the newsletter is in the description below as well. Do check it out, and I will see you next time.